Delirium is serious, costly, and can be fatal. Patients with delirium in the ED have approximately a 70% increased risk of death during the first 6 months after the visit. The ED is a critical point for identifying delirium, but 70% of delirium cases are missed in our EDs. Kathy lives with her daughter Emily, who brought her to the ED for cough, and because she feels her mother hasn't been herself lately. Her vital signs are normal, and she has a low acuity triage score. When we think of delirium, we often picture agitated or hyperactive delirium. But 90% of delirium cases in the ED are hypoactive, quiet, withdrawn, and sedated. These cases are not always obvious to clinicians.
Everything okay?
I guess. Is the doctor coming soon?
He'll be here when he comes.
Delirium is acute brain failure. In older adults, it is sometimes the only symptom of an underlying medical condition. Patients with hypoactive delirium may seem calm and comfortable, but their internal experience may be quite different. Delirium is a frightening experience for patients and their caregivers.
Are you the daughter?
Yes. Is she okay?
Looks like your mom has pneumonia.
Okay.
Luckily, it's not that bad. We are going to give her a dose of antibiotics here by Wayne, and then also prescribe antibiotics that she can take at home to help fight the infection. With antibiotics and proper rest, I think she'll be fine.
Would that explain why she's been so off lately?
Well, your mom has dementia, so that's probably all it is.
But look at her, she's never
If we
had
limit
this.
our assessments to just what we can see, we will miss important diagnoses.
Come on, Mom. It's time to go.
Kathy's pneumonia was addressed, but her delirium wasn't. Her daughter brought her back 2 days later due to severe lethargy. Kathy was found to have an acute kidney injury and severe hypernatremia due to dehydration and was admitted to the hospital for 7 days. At discharge, she was admitted to a skilled nursing facility due to deconditioning. A missed case of delirium is serious and leads to increased morbidity and mortality. But delirium is preventable, and there are things we can do in the ED to reduce risk. The onset of delirium is common in hospitals, especially in the ED. Luckily, we can take some simple steps to prevent delirium or lessen its severity.
Hello? Just checking in.
Hi.
The doctor may be well. When was the last time your mom had anything to eat or drink?
Actually, I couldn't even get her to eat breakfast this morning, so not since last night.
Okay. I'll bring her something for sure. Is she more comfortable sitting in the chair?
Oh, yes, absolutely. Thank you, yes. The room is actually pretty chilly in here. Any way we can get a blanket for her?
Sure.
Thank you.
Consider if your patient is tired, hungry, thirsty, retaining urine, or constipated. Is your patient overmedicated, immobile, cold, or physically uncomfortable, or in pain? We need to identify the underlying cause of delirium to treat it. But until we can determine the cause, ensuring basic needs and comfort of our patient are met can help prevent it from getting worse. These interventions can even prevent delirium from developing in the first place.
Hi, Mrs. Smith. I'm Dr. Sabir. And you are a daughter? Nice to meet you. Mrs. Smith, from the tests we ran, I can see that you have pneumonia. And I'll be prescribing antibiotics for that infection. Is something wrong? You look worried.
I'm sorry. This is not like her. She has dementia, but she's not usually this out of it.
What do you mean, this is not like her? What has changed?
Oh, she's usually up for breakfast every morning, takes the kids to school with me, works on the herb garden. She has her normal routine. But the last week or so, she's been sleeping more and more. And this morning, I could barely get her out of bed.
With a single question, what has changed? The doctor was able to identify a serious medical condition, hypoactive delirium.
It sounds to me like your mom is experiencing delirium. This is why she's acting differently. The delirium is probably caused by her pneumonia, but it's a serious condition that requires close monitoring. I think it will be safer for your mom to stay in the hospital.
Mom gets so frightened when she's all alone in the hospital.
People with delirium feel much better with a family member close by. Do you think that you or someone from your family can stay here with her?
Of course, but I thought I couldn't stay.
We can make an exception because you are providing important care.
Mom, I'm gonna stay with you.
It's okay, Mrs. Smith. You're in the hospital, and we're here to help you. Emily is here with you. She's going to be able to stay with you while we help you get better.
Take the extra 30 seconds. Ask the important questions. Involve family and caregivers, and expand your assessment beyond the obvious diagnosis. If we do this, we can prevent readmissions and improve patient outcomes and experiences. Remember, delirium is acute brain failure. 90% of delirium in older adults in the emergency department is hypoactive delirium. Collateral history is essential. Contact a caregiver to determine what has changed. You can decrease the severity of delirium and even prevent it from developing with some simple interventions that address physical needs, psychological needs, comfort, orientation, cognitive engagement, and mobility. And always remember that caregivers are not visitors. They are an essential part of the patient's care team.